Hello, everyone. It's awesome to be here. And I am the director of the course. And I really do hope you truly love the course. We got some awesome speakers, got some awesome presentations. And I really wasn't going to do another video, but, I was just thinking that, I am a pulmonologist and I really couldn't resist the temptation to do something pulmonary. And of course, when we think about pulmonary and sleep, it's got to be about sleep apnea. And one of my favorite phrases in the whole world is beyond the pearls. So that's why I titled this, which is going to be kind of a last minute review. So even though we have awesome sections about sleep apnea, both central and obstructive, I thought this would be a nice thing to kind of clump it all in together and give you some original questions. Okay. So here's going to be our road course for today. We'll start off with just OSA. We'll talk about, hey, what does the data show? What does the evidence show about CPAP? Primary prevention about certain diseases, secondary prevention. How do you get patients to keep their CPAP on and not rip it off, Then I want to talk about some advanced devices. So these are a lot of the bi-level devices. We'll definitely talk a little bit about AVAPs and ASV, adapted servo ventilation. And then, of course, I couldn't resist but putting some central sleep apnea stuff. Though it's a small, tiny percent of sleep apnea, it's still important to talk about it. Then we're going to close talking about obesity, hypoventilation syndrome, and in individuals who are going to be hypercapnic, secondary to the OHS, not secondary to COPD, not secondary to neuromuscular disease, but truly hypercapnic from OHS in itself. So with that being said, I put a ton of questions here because I just thought this is what you need right before your boards and stuff. So let's just start off talking about OSA. So, when we talk about obstructive sleep apnea, if you look at the left and you look at this little picture, why does this individual look confused? Is because when we talk about how does sleep apnea, obstructive sleep apnea present? Well, I think if you're only thinking on board exams, it's going to be snoring and being overweight or obese, then we're going to be missing a big chunk of people. One of my take-home messages of how obstructive sleep apnea presents really is going to be based upon things like gender. And the way it presents in women is going to be different than it presents in men. When we talk about OSA, the way it presents in younger individuals is going to be different than how it presents in older individuals. And I think it's very important to talk about these things because if I were to ask the one-dimensional question, what happens to the incidence of OSA as we get older, it goes up and up and up. But they're not presenting in the classic way. So I'm going to give you some pearls about how obstructive sleep apnea is going to present. But I definitely put some interesting ones here. I said, hey, maybe the vignette says they're having a little more night sweats. I'm not saying that they don't have tuberculosis. No, I'm just joking. But of course, night sweats could be a unique way to present. Morning headaches. Someone who has nocturia is going to be important to realize that. And of course, a lot of the daytime symptoms like memory impairment. And of course, obstructive sleep apnea has been associated with so many things. So of course, I got to put things that affect the cardiovascular system, arrhythmias like atrial fibrillation. And of course, even when we talk about cognition and Alzheimer's disease, there definitely is going to be data that even as you get older in age, even when you unfortunately have something horrible like Alzheimer's dementia, there is some benefit for people to be treated for their obstructive sleep apnea. And of course, using the CPAP, even though it's not the easiest thing to do when you get older. So with that being said, let's just go to a question, So my first question, everyone, is with regards to the American Academy of Sleep Medicine scoring guidelines, which of the following statements regarding scoring of hypopneas is true? Well, and we'll work these together, okay? Is it going to be A, the preferred flow signal for scoring a hypopnea is the thermistor signal? Now, I got to tell you, a lot of the questions on your board exams are all about the evil M word. What's the M word? Memorize. You got to memorize these things. You got to read that scoring manual, So when I look at choice A, it seems to be wrong because when we talk about scoring hypopneas, what do we use? We use the pressure transducer. So pressure transducers for hypopneas, the thermistor is going to be the signal that we use to score what? Apneas. So just based upon that, I'm not picking A. That just jumped out at me as wrong right off the bat. B, the recommended rule for scoring hypopneas requires at least a 4% desaturation. So when I see this choice B, the answer is no, that's got to be false. Because this is going back to when we score hypopneas, well, how many scoring methods or how many guidelines are there where there's going to be the 1A rule, the 1B rule? And when we talk about the 1A rule, I always think that A stands for American Academy of Sleep Medicine, though it doesn't, because of course they'll have many ways to score these hypopneas. And when we talk about their desaturation, their rule, it's going to be 3%. When we talk about the 1B rule, now that looks more like the 4%. That's what we use when we talk about the Medicare guidelines. So when it says the word requires, well, no, it really depends on what rule are we using to score. So B is going to be wrong. C, arousals are required for scoring hypopneas by the recommended hypopnea definition. This goes back to, well, how many rules are there? There's 1A and 1B. So when we talk about arousals, we're going to be using the 1A rule, but when we talk about that rule, is it required to have arousals to score these hypopneas? And the answer is no. It's not like it's a must. It's like an either or, whether we're talking about someone who's having these desaturations and 30% decrease in flow, or you could use these arousals. So it's not required. Now, what about choice D? The duration of is going to be a hypopnea is a 30% drop in the signal excursion for greater than 10 seconds. Now that sounds really good because whether you use the 1A rule or the 1B rule, it's that 30% decrease in flow, and it's got to be at least 10 seconds. That's whether it's 1A or 1B. So you know what I'm going for here? I'm going for D as in dog. That's going to be the right answer, and I'm sticking to it. So, sorry, there's so much memorizing here. So remember that when we talk about, looking at flow, we use the pressure transducer. We're going to use the thermistor. Definitely, we're going to think about using the thermistor when we talk about apneas, and the pressure transducer when we talk about using hypopneas. But both of those, when we talk about apneas or hypopneas, they got to be at least 10 seconds in duration. Take home message. What about this one? This is going to be a 67-year-old man with snoring and witness apneas undergoes evaluation for sleep apnea. He has a level 3 home sleep apnea test, HSAT, which is performed. Which of the following is the correct calculation for what they call the respiratory disturbance index or the respiratory event index? And they give you a bunch. So what do you got to do here? You got to memorize. You got to know what's an HSAT versus what happens when you do an in-lab polysomnography, PSG. So when we think about RDI and we talk about a home sleep study, is that going to be equal to the apneas plus hypopneas? Like, I really like that part of it. But is it going to be divided by total sleep time? The answer is probably not, because if you want to know total sleep time, what's the old school way of doing it? Hey, it's going to be polysomnography, and I know when you have looking at the epochs, when you actually transition into sleep, and you can't really do that without the EEGs or other advanced technology. So if we do a home sleep study test, I'm not going to be dividing it by total sleep time. So I can't answer A as the right answer. What about B? Apneas and hypopneas plus some RERAs. Now, when we talk about RERAs, RERA, I mean, if we're doing a in-lab study, polysomnography, of course, you could score RERAs because you can look for the arousals. There are very specific things how you score arousals. But you can't really do that in a home sleep study. And once again, looking at the denominator, you're dividing by total sleep time, which you can't really get that in a home sleep study, especially this is a type 3, level 3 home sleep study. It doesn't say it's attached to actigraphy or anything else, just a level 3 home sleep study. You can't do it. So B is going to be wrong. Is it going to be, C or D? So one thing I do like about both C and D, you're dividing by total recording time, which is correct. So, you send them home. They, at least for the study, the types of level 3 HSATs we use here at my hospital, you press a button, it starts recording. We keep our, patients keep those for 3 days and they bring them back to us. But we do use total recording time. So which one seems right? Is it going to be C, apneas, hypopneas, or D, apneas, hypopneas, and raras? And I told you in a home sleep study, you can't score raras. So the correct answer here has to be C as in cat. C as in cat. All right. So this is going to be important, knowing what are we getting with a home sleep study versus what happens with an in-lab polysomnography. These are just high yield questions for the board exam. So I definitely would know those. All right. What about this one? Which of the following is true regarding clinical risk factors for OSA? Oh, I'm loving this one already. So which of these are going to be true? Women are more likely to present with snoring and witness apneas than complaining of daytime fatigue and mood disturbances. That sounds totally wrong. So I kind of hinted at it. When you don't know how sleep apnea, obstructive sleep apnea presents, it really depends upon gender and age. And we really are doing a pretty bad job about diagnosing OSA in women. In fact, it's frequently underdiagnosed and misdiagnosed because women tend to present more with daytime fatigue and mood disturbances and their workup for depression than the classic thing that we think about with most men, which is, are you snoring heroically? So A is going to be wrong, but I would take my little pearls about that, talking about A. B, obesity is associated with an anterior-posterior collapse of the upper airway. So, what does that mean? How do you know it's an anterior posterior? Well, you're probably going to do something called DISE, drug-induced sleep endoscopy. And usually when we talk about DISE, you're thinking about something like putting in the Inspire device, but you want to see how the airway collapses. So when we talk about a anterior posterior, that's the type that you probably will plug in someone to have that Inspire device, that hypoglossal nerve stimulator because of that collapse of the tongue. But if you have obesity, that's more like a concentric collapse, So I'm going to go wrong with B, wrong with A. C, there is less association with sleep symptoms among older adults compared to middle-aged adults. So I want to say that, once again, age plays a huge part of it. And so when we talk about older adults, I'm kind of loving, A little bit more. So I do agree, when you get older, there's a less association with sleep symptoms, because older people actually might be more concerned about nocturia and what's going on over there. So they may not have the classic sleep symptoms of the heroic snoring. They'll have other symptoms. And I would say middle-aged adults will probably have more of the classic symptoms. So I'm loving C. I could be wrong because I'm just doing this with you folks, but C's looking good. But let me just go through the other ones, because it happens all the time. You don't want to pick something before you read all the questions. There is a stronger association between body mass index and obstructive sleep apnea among Asian patients compared to Western countries. So I'm going to go wrong on that. If you guys don't know, I'm half Indian and half Filipino, so I could speak on my Asian Filipino side that a lot of Asian individuals, they don't have OSA based upon just body mass index and being overweight or obese. It's really the anatomy of the upper airways, right? So I'm going to say D is wrong, because there's less of an association between BMI and OSA in Asian patients. And E, longer thyromantle distances increase OSA. So if you have any pulmonologists listening today, what really increases for OSA is a short thyromantle distance. And that's where we, before we intubate patients, we see how many fingers are under here to look at that ballpark thyromantle distance. So shorter risk of OSA. So I'm going to go with C over here, everyone. And the take-home message is that older adults will definitely have different symptoms than younger adults with OSA, and it's going to be less of the classic heroic snoring type symptoms. So C, I'm going to go with the right answer. Yes. And anyways, this is my folks. My dad, he had some OSA, and that's him. There's my mom. She doesn't. And that's us giving a little group hug right there. I told you my mom is Filipino. No one believed me. That's why I had to put the picture up there. So, um, here are some things I want you to know for the boards. This is just memorizing. Sorry about that. So obstructive apnea criteria, sensation of airflow greater than 90%. What do we use? The thermistor. It's got to be at least 10 seconds in duration. But the key thing is that oxygen desaturation is not part of the definition. And that used to really confuse me. I'm like, because all of us know that we have OSA patients when we squirm in the lab, they totally desat, but it's just not part of the scoring criteria. Okay. But of course, clinically, we see them desat all the time, Obstructive hypopnea is two main criteria. There's going to be the 1A. And I just said, hey, it reminds me of AASM because there's so many ways to get the diagnosis of OSA. Sensation of airflow greater than 30%, 3% desaturation oxygenation from baseline, or, and the key word here is or an arousal. Back to the first question where it's not mandatory to have an arousal. It could be or an arousal. And it lasts for at least 10 seconds. The 1B scoring, once again, sensation of airflow greater than 30%. This is the 4% decrease in oxygenation, but once again, it still lasts for 10 seconds. And then there's RARAs, which usually we score in lab because there is very specific scoring criteria to score an arousal, and it can't meet the criteria for an apnea or hypopnea. And this is going to be important if you really kind of like this stuff and you want to brush up on scoring for the board exams. One of the videos, some of the lectures we have here is from one of my respiratory therapists who are just awesome when it comes down to scoring, and I hope you folks really like it. I learned a lot from it. So when we talk about obstructive sleep apnea, there's no questions asked. What is the gold standard? It's always going to be polysomnography. In the olden days, the best initial screening test, which we don't do that much anymore, was pulse oximetry. Put a pulse ox on there and look for certain patterns of desaturations. But the key thing is if you do a pulse oximetry for a screening study, you don't know what's obstructive, you don't know what's central, you're just kind of seeing some desaturations. So if you suspect obstructive sleep apnea based upon your criteria like stop bang questionnaires, if you suspect it, you're going to diagnose it with what? Sleep study, no questions asked. You don't need to screen for it. When do I use oximetry? I think we all have had patients who have OSA, they're on CPAP, and we think they also will require oxygen, even though they have optimal CPAP. And that's sometimes what we do. We'll make patients wear their CPAP at home, they wear a pulse ox, and see what happens to their oxygen levels despite optimal CPAP. And then we'll see if they need to have a home oxygen concentrator to bleed some oxygen into the CPAP device. But the gold standard is always going to be in-lab polysomnography. We don't do as much of those as we used to, which is a shame because that's why we have fellowships, because of polysomnography. Of course, you could do a full night diagnostic. You could do a split night study. And of course, poly means many, somography means measurements, and it has many measurements. If you ever get for most home sleep studies, with the exception of something called the watch pat, what we'll talk about, anytime you see central sleep apnea, you definitely want to do an in-lab study to confirm it because central sleep apnea is definitely going to be a rare thing to see. The reason why I said maybe not with something called the watch pad, it actually got approved FDA-wise to diagnose central apnea. So if you feel comfortable with it, but central apnea is just so uncommon that I usually always will back it up by getting an in-lab study if I see it. And, preaching to the choir over here, here's going to be severity when we talk about the apnea hypopnea index for OSA. And I guess the big question is the AHI the best measurement of severity for obstructive sleep apnea? Because the truth is not all apneas are created equal, even though we have the definitions that we just talked about. Some people have super, super long apnea. Some are associated with really significant desaturations. So is AHI the best marker of severity in OSA? The question is still being answered, but as for now, this is going to be how we categorize severity of OSA as normal, less than 5, mild, moderate, or severe. So if we're talking about type 1, 2, 3, and 4 studies, a type 1 study is a polysomography, and this is something where we look at the EEG leads, then we look at the effort leads down here. And of course, if you want to get more pearls about scoring sleep staging, you definitely could watch the videos that we have in our course that are just amazing. But you want to score using 30-second epoch. Obviously, I'm really compressing this here, but this is REM stage. Somewhere in there, I'm sure there are some sawtooth waves, not necessary for REM sleep. I'm sure we have the classic eye movements. I want to look at the muscle tone to see that decrease in muscle tone. And of course, down here, looking at trying to score the respiratory events. Right here, I noticed that there is no flow and there's effort. Classic is what we see in obstructive apneas, and it's no coincidence I put it in REM sleep. We see obstructive apneas the most in REM sleep due to that lack of muscle tone of the upper airways. So home sleep studies, everyone, are just taking off, especially, we just are finishing our pandemic. I think we're in the endemic now, but of course there are many benefits of doing a home sleep study. Less first night effect, just be nice to the patients who are homebound, who are older, who have chronic illness. And of course, when do we do home sleep studies? When you have a very high pretest probability. If you have a low pretest probability, you do an in-lab PSG first. And of course, if you have a high pretest probability and the home sleep study does not show what you suspect, you would strongly consider doing an in-lab study at that time. So I put this here for the types of devices. Type 1 is a polysomnography. So type 2 has a minimum of 7 channels for recording. A type 3, which is what we use here at my hospital, has at least 4 channels. And type 4 device is going to have 3 channels. And there is something called the PAT, peripheral arterial tone, which I'll show you a picture in 1 second. So this is what we use at my hospital. And what are going to be my channels? There's respiratory effort, pulse ox, pulse in itself, meaning heart rate, nasal flow, and of course snoring. And this is someone just, resting comfortably, enjoying their home sleep study. WatchPat, I wanted to mention, is going to be an algorithm, and it's based upon when you have obstructive apneas, you get a little sympathetic surge. And when you get that sympathetic surge, what are you going to do? You're going to vasoconstrict. So it's going to be arterial tone. And based upon this algorithm, they've correlated, changes in peripheral arterial tone with the diagnosis of apneas. And it can be disposable, which is pretty cool. And this is one of the older ones are up here that are non-disposable. So what about this 60-year-old moderately obese man is referred to the sleep clinic for long-standing snoring and excessive daytime sleepiness. The patient has no significant cardiovascular or respiratory comorbidities. The patient averages 7 to 8 hours of unrefreshing sleep per night. That's associated with morning headaches and witness apneas. His Epworth is 16, which is elevated. I'm sure the cutoff for most of you folks is like 12 and above. His collar size is 17 inches, and of course that's a huge risk factor. Greater than 17 for a man, greater than 16 for a woman. And he is observed to have a very small mandibular size, another risk factor. They do a home sleep apnea test, as you should, because there's a very high pretest probability of OSA. Had a nice recording time, 13 apneas, 21 hypopneas, and when you did all the mathematics, the AHI is 4.1, which is normal. Mean oxygen saturation is on the lower side, but 91%. It was less than 90% for only 15 minutes, which is the best recommendation for this person based on the fact that you really thought they had OSA and the AHI is only 4.1. Would you A, repeat the home study? That's not a bad idea. Would you B, say, you know what, let's go for the gold standard, do an in-lab polysomnography? C, hey, you pretty much have OSA. Let's just give you some auto-titrating PAP. Or D, you know what, I'm really worried more about this O2 sat less than 90% for 15 minutes. Let's just give some supplemental oxygen. And the answer is going to be what? Go for the gold. We just can't settle for a home sleep study saying negative with a high pretest probability. He needs what? An in-lab polysomnography. C, you can't really give C. I guess you could give C, but how is it going to get covered? How are you going to plug this patient in with a durable medical equipment company? You just can't. You need to have a positive study. So the answer here is going to be B as in boy. Great job. Great job. And of course, Some of the reasons about why the HI could be lower could be mathematically. You're dividing by what? Total recording time instead of sleep time. So home sleep studies definitely underestimate the HI. And trust me, not in a mean way, because I love all my patients. You can show them how to wear that belt and do a home sleep study as much as you want, and they'll just put it in the wrong place. They won't hit the button. There could be a lot of technical things that happen also.